morning and welcome to the 2026 MPE Masterclass. My name is Barbara Leonardi and I am the President of the Board of Directors of Myeloma Patients Europe. I am so honored that so many of organization leaders, patient advocates, partners, friends, and special guests accepted our invitation and are going to spend this special weekend with us. This is a rare and very unique opportunity to have so much knowledge and so much expertise in one room. So I really would like to encourage every participant to take this opportunity, embrace it, learn from each other, exchange, share your good practices, because you have a lot of knowledge to give to others. I really hope this will be a great time of collaboration and networking, and I do hope that some new friendships and new collaboration opportunities will be the result of this meeting. Also, I would like to take this opportunity to recognize a few special individuals. The board of directors, a few people who volunteer their time and their effort to make sure that the mission and vision of MPE is on track and is delivered, and that you all can enjoy the work MPE is doing. Please take this chance and have a chat with these people today. Ask them about their duties, and remember, while they are the ambassadors of MPE outside, they are also your representatives in the conversation with the Myeloma Patients Europe professional team. Let me welcome and introduce Diana Lenning-Martens from Germany, Snežana Doder from Serbia, Zvi Zilberman from Israel, Kristina Modic, Slovenia, Lidia Pečová, Macedonia, Rika-Liina Maninen, Finland, Vince Klaus, Belgium, and last but definitely not least, Eric Battini. Thank you so much for your hard work. We just spent a couple of days working together and discussing also the plans for MPE for the future. Thank you. And it's really a pleasure and privilege to be working with you. As you know, this year we celebrate the 15th anniversary of Myeloma Patients Europe. And we celebrate it in many various ways. You all received your beautiful t-shirts in your starter packs. And also, we will recognize it in the form of scholarships. So this year, it will not be 10 scholarships as usual, but 15 to mark the 15th anniversary. The winners will be announced later today at the end of the day. And now, we will play a short video to show some memories of these 15 years. Thank you. It's a mutual effort, all these 15 years and the work MPE achieved. It's a team effort. And now, to officially open our 2026 MPE Masterclass, let me invite to the stage two special guests. Professor Maria Gomes da Silva, President of Portuguese Society of Haematology. And Professor Manuel Abecasis, President of APCL and former Director of Haematology and Bone Marrow Transplantation Unit. Professor da Silva, can we?
Hello, good morning, everyone. I only want to say a few words because you have a lot of work to do during the day, so this is not to take too much of your time. But on behalf of the Portuguese Society of Haematology, I have to say that I'm so honored to have been invited to open this session. I've been working as president of the Portuguese Society of Haematology for now is the third year, but I have already experience in the society. I've been working closely with Professor Abecasis as part of the Portuguese Association Against Leukaemia, which also includes multiple myeloma, not only leukemia. And most of all, I'm a clinician working in a hospital not so far away from here and very close to the patients and patients' problems. And what I have to say is that in all these different roles that we play all at the same time, because time is something that we don't have a lot, I've been learning a lot from my patients and from the patients' organizations I work with. So I learn how important it is to hear the voices of the patients, to learn about how can we plan our scientific work, let's say, when we plan like a clinical trial or a review of a problem, to understand what is the patient's perspective, to understand which are the important endpoints for the studies, because we might not see things exactly the same way. But if we make a habit of discussing endpoints, problems, questions, like how do indolent diseases evolve into aggressive disease? Which are the important toxicities? I can see a toxicity in a different way than you see. If you don't teach me, I will not understand it correctly. So I've been having in my career a learning curve about the inputs our patients and patient organizations are able to give to the clinical work I do every day. That's why it's so rewarding for me to be here to represent a scientific society that is working closer and closer to patient organizations. We have, as the Portuguese Society of Hematology, a huge focus on education. I'm not thinking about patient education, I'm thinking about clinician education, which is, of course, makes sense, about scientific development. But we also started having many collaborations on patient, I wouldn't say education, but growing knowledge about their diseases. That's an important work to do, not only to transmit to patients what the disease is, what the treatment options are, but also what are their priorities and what is their perspective about the disease and the treatments. And I think we came up with nice projects and knowing much more from each other, changing the way we look at science and at education both ways. So I don't want to take more of your time just to tell you that I'm so happy to be here. I'm so happy that you have chosen Lisbon, which is a very nice city, especially today because it's sunny. And I hope you have a wonderful 1.5 days. I know you started yesterday already, so almost 2 days. Very productive work, and that you end this actually celebration of 15 years even better than you started today. Thank you very much for the opportunity, and have a wonderful 1.5 days.
So I haven't been invited to the podium, but I suppose I could just follow Maria. I must say that I don't have much to add to what she said, because I think she told you almost everything that had to be said. I'm also very honored that you have chosen Lisbon for your masterclass. Also, I think marking a very important date, your 15th anniversary, which is really an outstanding mark. And I was thinking about yesterday, when I was thinking about this meeting, I found myself thinking about my own experience with myeloma patients, because I'm very old, much older than all of you. And I remember well when I was a resident training in hematology, the head of the department would offer the young doctors the possibility of choosing an outpatient clinic, either acute leukemia or chronic leukemias or myeloma and so and so. And I remember that most of us would avoid having the myeloma clinic because there was very little to offer to the patients. I mean, we used melphalan and prednisolone a long time ago, and then VAD, which was an aggressive chemotherapy regimen. But then suddenly everything has changed, and myeloma has become a fascinating field in hematology with all these new approaches which do not involve chemotherapy, involve much more rational ways of dealing with the disease, knowing the biology of the disease and having the opportunity to use drugs that interact, that have a very, I would say, intelligent way of dealing with the disease has entirely changed the field. And it's really one of the most attractive fields in hematology today. And I'm very glad, I'm very happy about this, because I know that most of you, if not all, are already benefiting from these advances in medicine and in science. And I also wish you a very fruitful meeting. I think this is really a challenge situation, and we all need to learn from your side, from patient-reported outcomes that can help a lot. Thank you very much, and enjoy your meeting. Thank you.
Thank you so much. So now our masterclass is officially open. And we can move on to our first session. And typically we start with the treatment updates on myeloma, so we can learn what has happened, what has changed over the past year. Please welcome Dr. Fernando Leal da Costa, Senior Hematologist and Lead of Myeloma Clinic in Lisbon. Dr. Leal da Costa has many years of practice. He also served as an expert in the Ministry of Health of Portugal. Welcome.
Barbara, long time no see. Good morning, everybody. Thank you for the invitation. I would like to give you all, again, a warm welcome to Lisbon. Barbara, thank you very much for having invited me. Linda, thank you very much for your help. I have to make a disclosure. Linda sent me a whole range of topics I should cover. I'm only going to cover very few of them. Most of the things I'm going to say, you already know them, so please don't be discouraged. But I do believe this is very encouraging. As Manuel used to be my boss, just said, when we start, I'm not that young, okay, so I'm almost his age. I'm one of the very few madmen at the time, about 40 years ago, that became interested in multiple myeloma. I mean, effectively, we only had basically 2 or 3 medicines to treat multiple myeloma. As we'll see now, it's a completely different story, okay? Now, I hope this will work. Next. Okay. Did it work? Right, those are the topics, okay? I'm not going to go extensively through all of them, and I may actually skip a few, but it doesn't matter. Well, so, I mean, you all know what myeloma is, but just to remind you that this is the wrong name for the right disease. Myeloma shouldn't be called myeloma, but this is something that happened a long time ago. It has to do with the fact that in those days, whenever you saw something that was sort of marrow-related, was thought to be myo, so myo in terms of myelocyte from the marrow. So it was called myeloma, but people didn't know that, as a matter of fact, those cells actually, they strive in the lymph nodes, not in the marrow. It is the fact 1. And the fact 2 is that they are not myelocytes at all. They are a sort of derived lymphocytes. So it is a blood cancer that originates from plasmacytes. Again, another misnomer, because plasmacytes do not exist essentially in the plasma. They were seen in the plasma, and there was this very intelligent German that as he saw them in the plasma, he thought they should call them plasmazellen. So they became plasmacytes, but as a matter of fact, they should be called immunocytes. It is a monoclonal gammopathy. This means that these cells, normally, plasmacytes, as we call them, they are a sort of B lymphocytes that produce antibodies, okay? This is the whole simple story. This is a cancer of the cells that normally produce antibodies. It is a whole body disease. It just simply stays in the marrow. It affects the whole body. And, well, we've been using this acronym CRAB, which is not it. As a matter of fact, it's a picture of a crab that costs 5,000 euros if you want to buy it. Don't ask me why. It seems that it is actually produced by a factory in the north of Lisbon that is very much, I mean, I would say, upgraded. But it's from a Portuguese ceramist called Bordal Pinheiro. And this is the reason why this crab is so expensive. Well, anyway, and the other thing is, does myeloma exist before being myeloma? Well, it does. It's something that I've been taught many, many years ago. I mean, cancer doesn't start 3 o'clock in the afternoon on the 25th of April, okay? Don't worry. Unfortunately, it starts many, many years before we are aware of having multiple myeloma. So multiple myeloma has a precancerous stage. I won't talk about it because I've just noticed, well, I noticed when I was invited, that we'll have a talk specifically about the events that precede multiple myeloma. And there's a big question now, whether we should treat those events prior to having multiple myeloma. There's a big discussion about it. As we stand, the doctrine now is we don't treat myeloma before it needs treatment. Well, it seems logical. The question is defining when does it need treatment, okay? So this is multiple myeloma, ladies and gentlemen. It's the easiest disease for a hematologist to identify the microscope, okay? Do I have a pointer? Well, this is multiple myeloma, okay? This eccentric big cells full of substance in the cytoplasm, which as a matter of fact are antibodies being produced. Those cells, they have a problem. They produce a lot of antibodies that aren't of any use at all. And these antibodies, they don't work and they are toxic. And this is the reason why, one of the reasons why multiple myeloma, it's a bad disease to have. It was originally described in 1844, well, It was named multiple myeloma by this German guy. Again, he made a mistake. Kahler was the first one to describe the disease. This is the reason why you'll probably hear that this is Kahler's disease, okay? It's not Kahler's disease at all. It's not his disease. It's multiple myeloma. And the other stupid thing is that there isn't no single myeloma. Every myeloma is multiple by definition. If you have a single myeloma, a single tumor, it's called something different. It's called a plasmacytoma, which is again is a misnomer because it's not a tumor of the plasma. But then again, we doctors, we stick to old things. But it was only in the beginning of the last century that these guys over there, and there's a big discussion whether it is either the Germans or the Spanish. In Spain, they say they discovered multiple myeloma. Well, Ramon y Cajal, which is probably best known for having described the neuron, he was one of the first to identify that, as a matter of fact, multiple myeloma was a tumor of the plasmacytes. Okay, now, so this is a disease of the plasmacytes. Those are the cells that produce antibodies. The antibodies are immunoglobulins. They are called immunoglobulins because we thought that they were globulins. As a matter of fact, they are not globulins as such. They're not a glow, but well. And plasmacytes basically are activated B lymphocytes. Now, this is something that you must have in mind for the whole of the lecture. There are two types of lymphocytes. Well, there are more than two types, but generally there are basically two types of lymphocytes. The ones we call B, again, because they were identified in something that is something similar to the appendix of the chicken. Well, it's the bursa of, doesn't matter. So they call them B lymphocytes, and T lymphocytes are ones that are actually developed within the thymus, okay? B lymphocytes produce antibodies, and they produce antibodies when they are activated and transform into plasmacytes. And when this process goes wrong, and these plasmacytes became cancerous, we have myeloma, right? T lymphocytes, that again are a different type of lymphocytes. They don't produce antibodies, but they do a lot of things which are absolutely vital for us to survive as a species. They help B lymphocytes and other cells. They regulate the immune response, and some of them have this nasty name. They are called killer cells because, as a matter of fact, they kill the cells they come into contact with. And they are very important because they are the ones that are responsible for our immune surveillance of cancer. We are continuously, as we speak, as I speak, producing cancerous cells. Mistakes happen, okay? The number of cell divisions we have every minute is astounding. And you can have a mistake. It's something that can biochemically happen. So why don't we all have a whole bunch of cancerous cells? Because we do have immune surveillance, okay? That's one of the reasons why we don't have it. It's very important. And I'll go back to this because now, as I'll show in the end of the lecture, we can actually use these T cells, we can tame them to do what we need them to do, which is specifically to go after myeloma cells. Now, these are immunoglobulins, okay? They don't look like this, okay? This is just a very schematic thing of immunoglobulins. They have this Y-shaped form. The two tips of the branches are the ones that actually connect to the antigen, that is the molecule, which is normally a protein, that one needs to identify and eliminate. The down tip actually is normally bound to a cell, and they bridge the interaction either between cells, it could be T cells, neutrophils, whatever, and the thing that we want to get rid of. It can be a virus, it can be a bacteria, it can be any other substance. This is what these molecules are responsible for many good things and bad things like allergies, for instance. And they are classified according to the name, you can call it the characteristic of the size of the interior chains, which are called the heavy chains. And they can be alpha, beta, gamma, delta, epsilon. This is why we have AGA, AGG, AGM, AGE, AGD. That's it. Well, The most frequent ones are IgG, okay? So most of the myelomas are either IgG or IgA, although you can have actually IgD, IgE. I haven't seen an IgE myeloma, and I've been treating myeloma for more than 40 years now, but I haven't seen one. And IgM actually, although the disease that produces IgM, not typically, it's another disease which has a fancy name. It's called Waldenström's macroglobulinemia. It was discovered by this brilliant Swedish that was actually very much important for the development of the diagnostic and treatment of multiple myeloma. And the outer chains are called light chains because they are smaller, they are lighter, okay? And those light chains, just by accident, they are called kappa and lambda. Well, why kappa and lambda? Because they were discovered by a guy called Korngold and the other one was Lipari. So they became kappa and lambda. It doesn't make any sense, but that's it. Lambda is worse than kappa, okay? In Portugal, in Portuguese, we have this word, it's called escapa. It means that you get rid of. And we say, when you have kappa, you escapa, okay? Because K chains do not harm kidneys as much as lambda chains, okay? And I'll go back to this. Right. This is the normal electrophoresis. Again, it was discovered by a Swedish, Niselius. And it's very easy. You have, you put the proteins and then you make an electric current go through them. The positive one goes to one side, that's the albumin. The negative ones go to the other side, that's the gamma globulins. Actually, it's the inverse because they go to the opposite current. Never mind. So you have a spike, which you call M spike, monoclonal spike, and this means that this immunoglobulin is the same produced by every clonal myeloma cell. Cancer is a clonal disease. Okay, you have one type of cell that goes on reproducing itself, and they produce always the same immunoglobulin, either complete or just one of the light chains. This is how we characterize multiple myeloma. Right, clinical manifestations of myeloma, it's the crab, okay? Hypercalcemia, renal impairment, anemia, and bone disease, okay? So how come a cell that produces antibodies, when they go crazy, they harm so many organs? There are many reasons. I'm not going to discuss the pathophysiology of multiple myeloma. I just want you to know that the antibodies they produce are toxic, they harm the kidney, they are viscose, they produce hyperviscosity. Because they harm the kidney, which is the organ that produces the red blood cell simulator, that's erythropoietin in normal human beings, and also because they actually occupy space in the marrow, we have anemia, amongst other reasons. And they actually contribute to activating some cells that we normally have, which is called osteoclasts, that actually destroy the bone. The bone is always remodeling. We don't die with the same bones we've been born. It's just a question of size, okay? We are always rebuilding bones. And we rebuild bones through a conjunction of mechanisms that essentially involve two cells. The ones that destroy osteoclasts and the ones that build osteoblasts. In multiple myeloma, because of biochemical reasons that, I mean, would be a little bit cumbersome to explain now, we have a lot of osteoclast activation and we have osteoblast depression. So we have a sort of enhancement of normal osteoporosis to a point we have holes in the bones, okay, which are called lytic lesions. And because of that, well, this is the possible symptoms. And because of that, the main reason why you seek doctor when you have multiple myeloma, it's bone pain, okay? The second most frequent reason is tiredness. You have anemia. The second most frequent reason, which is effectively just seen when you do the analysis, is high blood calcium. And you have high blood calcium because you are destroying bone, so you have a lot of calcium that you actually can depose back in the bones. Sometimes you have fever, sometimes you have hyperviscosity with neurological syndromes, and not that often, but sometimes, essentially because of the damage you have to the spine, you may have neurological lesions like paralysis because you can actually break your spine. right? So bone pain, and I keep telling this to every doctor I spoke to, when you see someone with a bone pain and anemia, please think about multiple myeloma. Right, multiple myeloma is more frequent in older people, although this has been changing. So if you have an elderly people with persistent back pain and he actually complains of tiredness, please do not accept immediately that it's just the aches of the old age. These patients may actually have multiple myeloma, which is a treatable disease, and as we'll see, probably a curable disease, if not now, in a very few years. Now, this is a slide that actually tells us when do we need to treat multiple myeloma, and from then on, I'll be with a faster pace. We treat multiple myeloma. We have these conditions before you have the necessity to being treated. Just having a gammopathy, just having a huge number of IgG circulating doesn't mean you need to be treated. You must have it, plus you must have something like the Crab symptoms, hypercalcemia, anemia, renal disease, bone disease, or more recently, we came to the conclusion that even if you don't have all of it, if you have more than 60% of bone marrow, of plasmacyte infiltration in bone marrow, if you have more than 100 ratio between the light chains that we actually measure, the kappa and the lambda, if the ratio is higher than 100, we need to treat them. And if the patient actually has more than one bone lesion of a certain size, and you can actually do that now with magnetic resonance and a few other fancy methods, because we do have the capability to diagnose multiple myeloma very early now. So when we have this, we need to treatment, okay? So, well, there is not one myeloma, okay? So what I've been telling you about is generic, but as in every cancer, there are all sorts of myelomas. Cancer is a gene disease. So as you can see, if the genes differ, if the genes that are affected differ, we have different types of myeloma. And for this, and for a few other reasons, not all myeloma is the same, okay? And the other thing is cancer is a very egotistical disease, as every cancer, but they need a lot of help. I'm going to show you why. So this is the new classification for genetic risk. It has been changing all over. It may change in a few years' time. The message to take home is that we are now able to identify some alterations in multiple myeloma that have prognostic meaning, okay? So we do know now which myeloma is nastier than the other, and we may, as a matter of fact, modulate the way we treat them. Right, myeloma is egotistical, but they depend on a lot of cells. Essentially, the bone cells I've just mentioned, and what we call the stromal cells. Bone marrow cells, I mean, any cell in the human body doesn't live alone. They need to interact. And the reason why I bring you this is because now we do not only treat myeloma cells, but we go after them, making their life miserable, attacking the other cells they need, okay? So if we treat the bone disease, if we, in a way, inhibit osteoclasts, we diminish the production of a molecule which is called IL-6 that is absolutely vital for the myeloma to thrive. So this is to bring you that what we do now have, it's not only a constellation of treatments to specifically go after the myeloma cell, it's a combination of things that actually involve the stroma and the bone disease also. And that would be a completely different topic. Now, is complexity an advantage? Well, yes and no. It is a survival advantage for the myeloma being so complex because it can evade lots of mechanisms that we have in place to get rid of it. But on the other hand, being so complex gives us the opportunity to find so many targets that we can actually reach to destroy the myeloma cell. And this is the major advancement. When we started that many years ago, we only have cell venoms. The only thing we had was medicines that actually would impair DNA functioning. And those were stupid mechanisms. Some of them, we still use them. But they kill every kind of cell. They just don't kill myeloma cells. And the main difference nowadays in oncology in general, in myeloma in particular, is that we do now have medicines that specifically go after the myeloma cells and leave the rest of the body sort of alone. Right, there are all sorts of myelomas. Myeloma comes in different guises, okay? I've just mentioned plasmacytomas. I've been talking about classical myeloma with bone, renal disease, anemia, whatever. But as a matter of fact, there are some diseases, some patients with myeloma, where you have several plasmacytomas, those tumors that don't seem to be interconnected. It's been now named multifocal bone disease. We may have multiple myeloma outside the bones, outside the bone marrow. It's called extramedullary disease. It's nasty. It can happen from the beginning. It can happen in an advanced stage of the disease. It may involve the lymph nodes. Obviously, you wouldn't expect that, but also, for instance, the liver, the skin, a few other organs. And we do have this condition, plasma cell leukemia, where we have a lot of plasma cells circulating, huge amounts of plasma cells circulating. We used to think that plasma cell leukemia was a sort of a different disease. Nowadays, the doctrine is that plasma cell leukemia is a type of advanced myeloma that starts in the beginning. Because the major change that we now have in concept is that we all know that every myeloma starts to be a gammopathy of unknown significance. And even before that, there's a genetic alteration that you can go after. Like in leukemia, you can go after SHIP, which is clonal hematopoiesis of indeterminate prognosis. We have something that we can actually call MIG or whatever, which is basically monoclonal gammopathy of indeterminate significance. Well, after that, we have MGUS, and then we have indolent myeloma, and you have a myeloma, but you don't need to be treated, okay? And plasma cell leukemia is at the end of the range. It's the most advanced form of multiple myeloma. Right. So, upfront treatment of myeloma is more better? Yes, it is. Well, we have known for many, many years, and this has been investigated first in breast cancer, then in lymphoma, and afterwards in multiple myeloma, that if you combine more than one drug when you start treating, you have a higher chance of avoiding resistance. So we go for multiple targets, we take advantage of the complexity of the cell, and we target different, I would say, metabolic pathways of the cell. And so we have been developing guidelines. These are the latest ones from 2025. It has been changing a lot. I just want you to know that what we do now, and because we are absolutely certain of what I'm saying, is that whenever you can, if you can use at least 4 different medicines as the upfront treatment of multiple myeloma, the chances of getting remission or even cure are much higher, okay? We started with 1, then we had 2. Actually, we always start with 2 because we had corticosteroids plus melphalan plus cyclophosphamide. Then we came with proteasome inhibitors, which is basically the inhibition of the system that the cell uses to get rid of the things they don't need. If we eliminate that, if we eliminate their sanitizing system, they'll die. We have immunomodulation, all sorts of things. So 4 is better than anything else. The other thing is, should we intensify or not? When we started in the early 90s of the past century, late 80s, we actually came to the conclusion that if it was possible to give a very high dose of the first ever medicine to be used in the treatment of multiple myeloma, which is melphalan, we had this impression that giving a lot of melphalan would be good because it would circumvent the resistance of myeloma cells on one hand, and it would be more effective, okay? And because of that, because simply of the need to give huge amounts of melphalan, which in those quantities would eventually kill all patients, autologous bone marrow transplantation was invented, okay? Simply to circumvent side effects. Autologous bone marrow transplantation does not treat multiple myeloma, right? Autologous bone marrow transplantation, the only thing it does is to prevent the patient from dying from the side effects of high-dose melphalan. So we've been discussing whether it should be high-dose melphalan alone with radiotherapy, a few other things. Doesn't matter. High-dose melphalan, 200 milligrams per meter square is good, but not everybody can have it because they have comorbidities or because simply they are older. And multiple myeloma is a disease of the old people. Unfortunately, we have seen it more and more often in younger people, but traditionally, if you are older than 70, the probability of you, despite autologous bone marrow transplantation, survive a high-dose treatment is actually lower than if you are younger. So there's a group of people that actually cannot be transplanted. There's been a lot of discussion whether we should going on doing high-dose melphalan. Yes, we must do it. This is the determination trial that actually compared what we thought then was the best treatment, 3 drugs, bortezomib, lenalidomide, and dexamethasone, plus either high-dose melphalan or just go on keeping the treatment of VRD. And we came to the conclusion that in terms of progression-free survival, that is the disease not coming back, it was better to have high-dose melphalan. It is the reason why we still do it. And although the survival, the overall survival is not different, and the reason is very simple, because now when people relapse, you can still treat them, okay? So it's better because you have a longer remission, and because of that longer remission, we can actually treat patients later, and as I speak, being treated later is better than the need to being treated sooner. And the reason is very simple, because I have patients that I now am treating having relapsed 10 to 15 years later, and I'm giving them things that I didn't have at that time. So I gain time, okay? They gain time, right? So this is the reason why it is important to give something that prolongs remission. Well, now, after that, we had 2 trials with the introduction of daratumumab, which is a monoclonal antibody that goes after a marker that multiple myeloma has, CD38, with the introduction of daratumumab as a first-line treatment, plus 3 drugs, bortezomib, thalidomide, and dexamethasone, and more recently, bortezomib, lenalidomide, and dexamethasone. Finally, we have a survival difference. This means that the prolongation of progression-free survival is so impactant that despite we now having treatments that are more effective when the patients relapse, the single fact that we have extended progression-free survival translated in a survival advantage. There are 2 trials that actually look into the new combination, which is the standard, I would say, upfront treatment of multiple myeloma, daratumumab, bortezomib, lenalidomide, and dexamethasone, plus high-dose melphalan for those that can actually have it, plus just maintenance of that treatment for the older patients or any other that doesn't has the ability, physiological ability of being treated with high-dose melphalan. And that's the Perseus trial and the Cepheus trial. I love these names. And both trials, and this is very important, both trials have been modulated using exactly the same technique that the regulatory authority in the UK, NICE, uses to forecast economical advantage. And this modulation showed that either in Perseus and in Cepheus, which is the patients that actually don't get to be transplanted, using 4 drugs upfront translates into a survival advantage. So this is the standard of care nowadays. Right. Same thing for isatuximab. Instead of daratumumab, it's another CD38 antibody. Again, another option. Instead of using daratumumab, you can use isatuximab plus 3 drugs. So what we call quadruplets is the standard of care as upfront. So for how long do we treat? Well, it has been shown, this is a major advancement, that after you give high-dose melphalan, if you keep giving lenalidomide, and we're not sure whether one should have it forever or not, this is another discussion we're still having. The thing is, if you give induction treatment, intensification plus maintenance, you actually give a survival advantage for these patients. So we came to the model of treatment that we used to actually, and we still use in children's and in adults lymphoblastic leukemia, which is intensification, which is induction, intensification, either you or not consolidate, plus maintenance. We do maintenance with lenalidomide now. We have tried to use it with thalidomide, before that with alpha interferon, but it has been evolving, and there are new trials that we actually use daratumumab with lenalidomide for maintenance. Well, I'm going to show you just 2 trials that actually went after the question I've just formulated before. Should we treat forever, or is there a point where we can actually stop maintenance? And we do now have a way of measuring residual disease. You'll have a talk about minimal residual disease. And there's this idea that it is actually possible. This is the MASTER trial in the US, there's the MIDAS trial in Europe, that actually show that if you get to a point where you have minimal residual disease, which is another way of, saying almost absent disease, after a few years you can actually stop. But, as this slide shows, if one is unfortunate enough to have certain specific and cumulative cytogenetic abnormalities, this is not true. So there's an unmet need, which goes for the patients that upfront have more than one cytogenetic alterations I have shown before. The very high-risk patients, we cannot stop it. The low risk or standard risk, as we should call them, if we are absolutely sure that they've been out of disease with minimal residual disease for more than 3 years, we could probably stop the treatment as it has been shown there. Okay, this is the MIDAS trial. Actually not. This is the concept trial, which is something that the Germans did. Basically, always the same question. Can we stop? When can we stop? And the impression is, if you are confident enough that you don't have the disease, plus you don't have cytogenetic alterations, you can actually stop after a few years of complete remission. Now, what if come back? Well, this is the story of multiple myeloma, but there are lots, because the disease, unfortunately, for many people, is not yet curable at the beginning. But the good news is, and I've said before, we can always retreat it, okay? But there are lots of factors that we have to actually figure out when we retreat a patient. How was it treated in the beginning? For how long did it stay in remission? How did it actually behave physiologically to the first-line treatment? Sometimes patients are older now when they relapse. Their physiological conditions are not the same they had 10, 20 years ago. So there are a combination of things that we must consider, and this is the good news. Very busy slide. This is the latest guideline, and mind you, guidelines are systematic affirmations that are evidence-based, made to help patients and doctors to make the right decision about their specific treatment. So there are lots of options. This is good news. We only had 2 or 3 medicines. Now we have lots of options. There are things we can repeat. There are things that we can actually change. And tendentially, in oncology, we tend to use different medicines whenever the disease comes back, because we believe that the disease has evolved. So we have to go for new targets. And you say, well, you've just spent 4 targets, an anti-CD38 antibody, plus a proteasome inhibitor, plus an immunomodulator, plus a corticosteroid. Is there anything left? Yes. Yes. There are lots of good things left. I'm going to show you a few of them. Well, you'll have a talk about this, but this is absolutely, I think this is intuitive. Having less cancer is better than having more cancer, okay? So minimal residual disease, it's always good. And one of the reasons why we use those quadruplets is because the probability of achieving minimal residual disease is higher than with just 1 or 2 drugs, okay? Now, new things. This is something I like a lot. This is the combination of a new drug. It's called belantamab. It's a combination of an anti-BCMA, which is something that specifically B cells do have when they activate, so plasmacytes have it. And this molecule is an anti-CD38 that goes combined with a cytotoxic that actually inhibits cell division, right? So this is very clever because what you have is an antibody that is basically the transporter of the drug we do want to affect the cell. And this is a study, very important, was published not that long ago. The conclusion is that this is licensed. It will be soon possible to use this as an alternative in second-line treatment, which is something that the patients haven't used before. Okay, corticosteroids is always there, but belantamab is an anti-BCMA. People have used an anti-CD38. Pomalidomide is a new IMiD. It's not lenalidomide, and a few other things are coming. So this is good news. We now have different monoclonal antibodies to treat multiple myeloma. And to the conclusion of this talk, we came to the things that are more, I would say, exciting, which are CAR T cells and bispecific antibodies. You do remember I've mentioned that we do all have T cells, and those T cells can be killer cells, and they can be tamed. We can actually teach them what we need them to kill, and we can actually make them more efficient, more proficient. Please remember, I mentioned that autologous transplantation is just a way of circumventing the side effects of high-dose melphalan. Now we came to a new way of looking at autologous transplantation. What we do is we actually take T cells from the patient. In the laboratory, we insert an instruction, a gene, that makes them produce a specific antibody that targets them to the myeloma cells. And there are lots of possibilities. We use BCMA, but you can use other things, and there are lots of testing going on with double combinations. I mean, it's a whole new field of investigation. And so the problem here is that we always need to have the right patient. This is not devoid of toxic effects. I'm not going to lose time explaining you all the toxic effects, because what we are actually looking for is pro-inflammation. We induce inflammation in the patient. That's what we want, because T cells, inflammation is an immune reaction. So we want the immune system to be activated. We are actually replacing chemotherapy by the immune system, okay? So what we do here is we have to take the cells, we have to take some time. We need to treat them, the patients, in between the medicine, the cells are being prepared. And then we lymphodeplete the patient. We take their T and B cells that are within the patient with some chemotherapy, not that much. Then we give the cells back. And we don't do anything else. This is amazing. This is a one-shot treatment. It makes a whole difference. And there are lots of trials. There are basically two specific medicines now in use, ide-cel and cilta-cel, for reasons that, I mean, doesn't matter now. Cilta-cel is more used than ide-cel, okay? The name of cilta-cel is too long for me even to remember it. It's blah, 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 autoclocel, okay? It's, well, it doesn't matter. But cilta-cel, given as second-line treatment, it can actually be curative, okay? And it is licensed in Europe. And what we are looking for and what we are fighting for, and we need the help of the patients' associations, mainly in Portugal, is that nowadays it is possible for us to use cilta-cel as a fourth-line treatment, okay? As you have seen, just a panoply of treatments we have. We can use second line, third line, fourth line, but not everybody comes to the fourth line. And the reason why we need this in second line is because it is probably curative, and sometime it may even be given in first line. It's a whole game changer. So CAR T cells change. But what about patients? Well, these are the number of targets that you can actually identify. Targets are antigens, proteins that the cells have in their skin, okay? Cells are identifiable by the molecules they have on their surface or in their surface, okay? So, and I say either on or in because they go through the membrane and they work as signals. They are signaling molecules. And what we can do is actually, with antibodies that we produce in laboratory, like the ones I have mentioned, daratumumab, is tuximab. Those are the ones we actually use more. There's another one we don't use that much in Europe anymore, but okay. And we can also teach T cells to go after these markers. And myeloma cells, from time to time, they do not express these markers, but we have different antigens. We can go, so there's been a whole field developing of immunotherapy. Now, if you don't have the ability to produce CAR T cells, and one of the problems with CAR T cells I've mentioned is because you have to take some time to prepare them. You take them from the patient, they go to the lab, and in the meantime, if the patient is progressing, you have to treat them. So there's an option, okay, which is doing exactly the same thing, sort of exactly the same thing in vivo. So what we do is that there are antibodies that can actually do the bridging effect. They are, as I've shown you before, they have 2 different epitopes, okay? Actually, they have 3, but what these molecules do is that they grab the T cell and they identify the myeloma cell and they put them in contact. And when the T cell sort of touches the myeloma cell, the T cell eliminates that. And goes on and on and on. Just the T cells, the good thing about them is that they only don't kill one myeloma cell. They are killing machines. There are videos that you can find on the internet about the velocity of T cells eliminating myeloma cells or any other cancer cells. So there's an option which is called bispecific antibodies, where you can actually have a molecule produced in the lab, and this is out of the shelf. You don't have to wait. You just have to call the pharmacy and give it to the patient. Obviously, it's not as easy as that because, again, there are some side effects. You have to choose the patients. You have to follow them. They have neurological toxicity. They produce a huge inflammation. They have to be sort of, the reaction we produce is so striking that we have to control that reaction, okay? And this exists not only for myeloma, but a few other cells that, a few other different cancer cells. And we now have anti-BCMA, in the pharmacy, which is basically teclistamab, elranatamab. We'll soon have linfoseltamab, etentamig, a few others. So many are coming, thanks God. Then we have a few that are actually developed, another antigen with GP5CD or GPR5CD, which is actually a completely different antigen, which is called talquetamab. And thanks God, we now have 3 specifics, okay? We have antibodies developed in the lab that then actually can go after one antigen, another antigen at the same time, and bring the killer cell in touch with these cells. And these are the results, it's our real life results, comparisons, statistical comparisons between what we can actually get with teclistamab, use it in 4th line. We don't use it yet in 2nd line, we'll go back to it. And standard treatment, and this is the same with talquetamab. So, which is the other antibody I have just mentioned, okay? Now, well, there are some differences in toxicity. Convenience is very important. Bispecifics are available immediately. This used to be done only as an inpatient setting. Within certain conditions, we can actually do this outpatient. We do it at the Oncologist Institute where we work. It's just down the road. And the thing is, can we actually sequence CAR-Ts and bispecifics? Yes, we can. If we treat one patient with a CAR-T cell, which is directed against an anti-BCMA, you can actually, if the patient relapses a few years later, we can actually treat him back with a bispecific antibody against a different antigen. So there are lots of options coming up. Now, this is the beginning of a new story. And this is the combination of teclistamab, the anti-BCMA, plus daratumumab, okay? So we are now using combinations of monoclonal antibodies sooner. And the good news is we are combining new options. Remember, I said that more is better because you have more targets available. Now we have been developing a few trials where we have been combining these new antibodies with drugs that we had already available, plus other antibodies. And actually, it has been published that we can actually use teclistamab plus talquetamab together, okay? And the sooner we do it, probably the better. So it's been evolving very fast. So this is a tri-specific. And even better news, remember I have just told you that we need to take the cells out of the patient, process them in the lab, and then giving back to the patient as a transplantation. What if we could actually tell the patient to produce its own CAR T cells without having to go through a cytophoresis, without having to wait a long time? And now we know it is possible. We can actually inject a virus or a nanoparticle that has the instruction that the T cells will capture and they'll activate with the new instruction we are giving them in vivo. So the trials that are now going on and are relatively advanced, either in Europe and in China, well, for many reasons the Chinese, they actually have the lead on everything that refers to immunotherapy of cancer. So in vivo, and this is a Chinese article, the in vivo, the production of CAR T cells, of engineered in vivo, specific modified antigenic cells, it's probably one of the biggest steps we'll see in the near future. I left out a few molecules like selinexor, which is an inhibitor of the molecule that actually exports the nasty molecules from inside the nucleus of the cell. I have skipped melflufen, which is a clever way of making melphalan more active and less toxic, just making it transportable with a small peptide so that it only goes inside the cells that are actually diseased. And I have skipped because they are in a very preliminary, I mean, I wouldn't say very, but they are still in the preliminary studies, which are CELMoDs. This is, please bear in mind these two names, essentially mexidumide. This will be the new kid in town, for sure, okay? Mexidumide is an evolution of lenalidomide and pomalidomide, less toxic, more effective, less neuropathy, probably more immunosuppressive. This is something I didn't mention because I do know you have a talk about side effects, including infections. As you probably have envisaged, if we are knocking out the myeloma, we are knocking out the capability of producing antibodies for every normal cell. So we are inducing immunosuppression. This is one of the problems that we have with these treatments. These patients, they may be cured of myeloma, but they are more prone to infections. And we don't want them to die of infections, okay? So there's a whole combination of things that we'll hear a little bit later, and which are essential for the good results we now have with multiple myeloma. We have better antibiotics, better antivirals, better antifungals, better diagnostic capability. Mexidumide has now been combined with bispecific antibodies, has now been combined with carfilzomib, which is a derivative of bortezomib, and do remember this name, Successor 2, Successor 3. The name, it's a lot, it's successing. These successor trials are the ones that involve mexidumide. So just to conclude, there are lots of things that we have to think of when you treat someone with multiple myeloma. Not just giving them chemotherapy or immunotherapy. There are lots of things that actually involve the whole family, the whole caregivers. I didn't mention, but there's a lot of work involving caregivers when you give someone a bispecific or a CAR T cell. But the message to take home essentially is that, well, new is not always innovation, okay? But fortunately, in multiple myeloma, we not only have a lot of new treatments, you have real innovative treatments. And innovation is here to stay. And I I'm absolutely sure that myeloma will be a curable disease before I retire, and I'll be retiring in 3 years' time. So I'm I am very confident. If not, well, I'll witness the developments at home, but I'll be glad to having, in a very modest way, to be part of all of this. Thank you very much.